audio's not kicked in yet. Fabulous. Okay, so welcome to December's Lisa and Pat chat. I really do like that. Thank you for attending, and for those that are listening to this after the live event, thank you for signing up and listening to it. As you know, there is always something that me and Pat have to talk about. Our job is never done.
No, it certainly isn't.
So I always get quite excited, Pat, because I find it, you know, as a practice manager, I'm constantly learning as well. There's, like we say, the job's never done. Compliance is never done. It's an ongoing thing, isn't it? So
yeah.
I know just before we came on that you'd got something quite interesting to share with us.
Yeah, absolutely. And interesting you should say you're always learning. Me too. You know, I pride myself on staying as up to date as I possibly can, but things do slip through the net. And I attended a really interesting lecture, online lecture on Monday, given by Professor Mike Lewis from Cardiff University, and it was called Infection Control: The 7 Deadly Sins, and there were some real eye-openers in it. And although I'm not massively surprised, but to hear him put some statistics on things and the level of non-compliance still out there, which was quite scary. But there were also things like I somehow must have missed that the antibiotic of choice is no longer amoxicillin. So it's gone back to being penicillin V, because amoxicillin is considered to be too broad spectrum. And in the interests of trying to prevent resistance and antimicrobial resistance, the powers that be, which is SDCEP, SDCEP, in Scotland, have decided that we should move back to prescribing penicillin V in preference to prescribing amoxicillin. So that was new to me, with metronidazole being the second drug of choice. So of course we're going to have to update all of our medicines management policy on that. So what do you do currently, Lisa? Were you aware of that?
I was made aware of it, but only recently. So in our practice, we pretty much introduced the antimicrobial prescribing new guidelines even straight away. It's kind of mine and Jilly, as you know, who we work with, our approach to it is it's the right thing to do. We should be doing it. It's a sensible thing to do. And there's been a little bit of sort of pushback from some patients. You know, of course, patients still have this idea in their head that if they have any sort of pain, they should be getting antibiotics. If they come in the scene and they're not given antibiotics, and then they do need antibiotics, it should have been given in the first place. So for me, it's about making sure we're completely educating everybody on it. And I know there was in the news, dental news anyway, last week about a gentleman who'd not had prophylaxis prescribed, and they're basically saying nice guidelines have killed him and almost killed him and things like that. But I'm shocked at when I go into visit practices where I say to the practice manager or clinical manager, how are you getting on with your antimicrobial prescribing? And they go, oh, they won't even discuss it. They won't discuss it. And even weirdly, this morning on a dentist group, there was a dentist that said, I'm in a practice and a lead nurse has asked me to take temperature before prescribing antibiotics. How dare they, kind of thing. And I was quite relieved. There was a few dentists that went, hello, you should have been doing this. And I'm sure you've come across people that still aren't getting on board with that.
Absolutely. Yeah, no, definitely, Lisa. And I think there are still masses and masses of incorrect antibiotics being given out for pulpitis, for toothache, which that is completely against the antimicrobial prescribing. And yes, the indications are that if you've got a fever or you've got infection that you can't drain that is spreading, then yes, antibiotics are the right thing to give, or the patient's immunocompromised. But I think there's vast amounts of inappropriate antibiotic prescribing, and the problem is that I remember before he died, actually, sadly, Martin Fulford saying to me that he lectured for us at the dentistry show, and he said that antimicrobial resistance will be an apocalypse, because we'll have no antibiotics to treat patients. So, isn't that interesting that it was the dentist that didn't know, but the nurse did?
Well, yes, this is the problem, isn't it?
Yeah.
And the dentist is potentially the registered manager.
Yes. Yeah, absolutely. Yeah.
It is worrying. I do find it worrying. It's like, this needs to be top of your list to get sorted. I know it's difficult because dentists generally don't like being told, particularly by managers or nurses, what to do, but do need to at least make an informed decision. I mean, it's not just about the antibiotics and the right way to treat people, is it? This is another step to prevent sepsis casualties. It's the right thing to do in my head, and I know the dentists that I work with here, we've reduced down completely what we're giving out when we're giving it out, but there is still practices, quite a funny story of practice that I visited, and I asked about it, and one of the dentists who massive, been doing dentistry for 40 years, said, okay, we can fill this out, we can follow this, but on the drop down box where you fill out what you're prescribing for, you've got various things you can tick, and he went, but where's the one that we would do for going on holiday? I'm like,
oh dear,
why we're doing this.
Oh dear.
Take some antibiotics just in case.
Just in case. Oh dear.
And they say that as being good customer service, and yeah, I get where they're coming from. But
yeah, I do too. And also, Professor Lewis said that, as we all know, the pandemic has made things so much worse because there was huge amounts of inappropriate antibiotic prescribing during the pandemic, but there was sometimes that was the only thing you could do, and but the problem is it has not dropped back down to pre-pandemic prescribing levels, and it's going on at this immensely high level.
There has to be more education for dentists.
There has to be, yeah.
This isn't a compliance tick box. This is way bigger, isn't it?
Yes, it is. It really is way bigger. Yeah. I think it's a massive issue, and I think, as you say, I think there needs to be a lot more. I think there needs to be a lot more education of dentists on that. So I think on that note, actually, I think certainly in my small area of influence, one of the things that I think I'll do is, because I do a monthly webinar on the dentistry forum, and I think maybe I'll make antibiotic prescribing at the top of my list for next year.
I mean, do you know what, Pat? If you want me to come along to that, I'm more than happy, because it will be potentially lead nurse, practice manager that helps to facilitate and implement it.
That's a good idea. Yeah,
don't have to do it themselves.
That's a good idea. Be interesting if we asked our audience, actually, if and just pop it into the chat, actually, is it a problem for you guys to in terms of getting the correct protocols in place for antibiotic prescribing in your practice, do you think? Because I noticed somebody put amen to that, Lisa.
Yeah, thanks, Laura.
Which is great.
Can we get a hallelujah for those that have managed to do it?
Yeah,
That'd be quite funny.
I'm curious to know. It is. I think it's a really big issue when and I'm a dentist myself, and I know that trying to get dentists to do things that they've always done is immensely difficult. Actually, immensely difficult. Somebody might drop stuff into the chat for us there, Lisa. So I think the other thing that was hugely interesting to me on this lecture was this level of non-compliance. So somehow they had managed to measure for all these different deadly sins how non-compliant practices were. So the first one he talked about was dental unit waterline management. That was sin number one. And he said that wherever the survey was done, 65% of practices are non-compliant with dental unit waterline management, and that was quite a big goodness me to me. So that's basically management of Legionella. Do you have any comment on that, Lisa?
No, I mean, I agree. There's constant conversations going on in practices where it comes down to the education, it comes down to the training within, it comes down to the manufacturers talking to us about it. And actually people getting the team to take the responsibility and accountability. The number of times you hear people say, oh, I didn't even know there was a filter on that chair, and things like this. Or something I saw the other day, someone doing tick sheets for a month in advance.
Yeah. Yes. I saw that on social media, actually. Yeah.
There's so much. And again, it comes down to people not understanding why we're trying to do it. We're not sat there bored or trying to make extra work for someone, but actually trying to protect people.
You're so right.
And this, again, it comes down to people just going through the motions with things instead of understanding why. I mean, for me, Legionella is something, I mean, I know we're talking, from the basic level to your daily routines to getting somebody to come and do your Legionella inspections. For me, that's something that should be happening.
Yeah. But in 65% of cases, it's not. Isn't that scary?
But the thing is, it costs a few £100s and a bit of time for your routines. But for the maintenance of these thousands of pounds of equipment that we use, it's protecting them as well. And the maintenance, definitely. I'm just going to say how much it costs, £200 or £300 to get a call out, to get your chair fixed, the suction goes off. And
no, absolutely. But I think also, the guidance that you should flush the water lines for 2 minutes every morning before you start surgery, just to sort of flush out any biofilm that's built up overnight, and also the 20 to 30 seconds in between patients as well, and none of that is being complied with in a big number of practices. So I think it's all about the Legionella stuff, but it's also about, which does cost a bit of money, I know, but it doesn't cost anything to flush through your water lines, and also to make sure that you disinfect your water lines correctly.
We've started, I know it's difficult, but we've started doing audits, spot checks.
Yes.
The team, Julie, who, as many of you perhaps know, does the compliance in my practices, she will pick someone to go and watch their setup routine and their breakdown routine and bits in between. And I'm not saying we have to do that every day, but people have to be accountable. for me, setting this out to the team, this is non-negotiable. This
Yeah.
isn't a if you get time, if you can.
Yeah.
It's
Yeah.
absolutely non-negotiable. This is not,
Yeah.
something that we're going to allow to not happen.
And do you think it's because people don't know why they're being asked to do it that they
Yeah.
don't do it? Yeah.
100%, 100%. They kind of know, they're not daft, are they? But they don't understand because, unfortunately, in a lot of the training courses, the microbials and cross-infection sides quite boring to them, I suppose.
Yes, I
They don't
guess.
see the
Yeah.
relevance of it. So I
Yeah.
think, again, we've got to understand why we're doing it and what consequences of not doing it are.
Yeah, absolutely. But one of my big mantras, which you'll have heard me say many times, Lisa, is don't do this because the regulators say you need to do it. Do it because it's the right thing to protect you, your patients, your staff, ultimately your families. Because I think if your infection control is really not where it should be, then you take all kinds of risks with your own health and with the health of others, and obviously your patients.
100%, and I agree. I mean, I know we've spoken lots and lots and lots of occasions, but do not leave the practice vulnerable. Leaving the practice vulnerable where things aren't done in the right way, you are leaving yourself open to so many problems from, as you've said, from a healthcare point of view, but also from a business side. It's like,
Yes, definitely.
Things, it's very good to have hindsight, but something like a Legionella issue, that could be enough to shut practice down completely.
Yes.
As well.
Yes.
So all those
Absolutely.
people's jobs, no wages being paid. It's like, I think that's definitely, I'm glad that's one of your top 7.
Definitely. And then the next one, which was a shocker to me actually, was infection control. So 50% or 57% of practices in this survey were not undertaking either not doing the audit or not acting on findings. And then the other thing that I've found from courses I've run is what you said, just going through the motions. So just ticking to say everything is correct. Well, that's a waste of time, money. If you do it on paper, it's a waste of paper as well. So, that's a big finding of the CQC actually, which is that either audits are not undertaken, or they don't reflect reality, or there is no evidence that actions arising from the audit have been acted on, in which case it was a waste of time in the first place.
Yeah, absolutely.
How do you make sure that your team does their, or how does Julie make sure that the infection control audits are done every 6 months and acted on?
We have them. We have a couple of different nurses that will do them. And Julie actually does them more regular, because we are a pretty big practice over two sites. So we do want to keep an eye on what's going on, especially having a big team. You have more of a turnover of team members as well. So we want to make sure that everyone is up to speed. But yeah, we are very, very, very diligent with audits. We audit everything because from Gilly's point of view, it's about doing the right thing and making sure everyone's safe. For me, I get the business side, development side out of it, because if everything's done well and we can talk about that and we can make sure we can be happy, the business is doing it for the right reasons as well. But it's about the team, and again, going back to this is non-negotiable. This is what we found, and we have the conversations of the findings and what we need to do, what we need to improve on. And
how do you make those things happen? How do you make sure those things happen?
getting it in the diary, making it robotic.
Yeah, brilliant.
This has
Yeah.
to be done
Yeah.
on this date and at that next meeting, which we've scheduled for 12 months, once a month, 12 months ahead, is, that is part of being well led and being safe and compliant.
Of course it is. Yeah. Of course it is. Yeah, absolutely. And then sin number 4 was another one, which is a sort of calendar thing, if you like, which was huge numbers of practices not undertaking validation of their infection control equipment. So obviously all infection control equipment have the daily, weekly, monthly tests. You've got the maintenance, you've got the servicing, and then you've got the validation. And actually, the biggest shock to me, I think, was a practice I went to a couple of years ago. Maybe actually, it might even have been pre-COVID anyway, a few years ago. And they hadn't had any inspection, validation, maintenance, or servicing of their equipment for 7 years. So they have no idea whether that equipment is working properly or not.
Because it worked every day, so they just carried on.
Yeah, exactly. So they have no idea of knowing whether it's effective or not. But not only that, going back to what you said, from the business perspective, if you don't look after your equipment, then it will let you down. And
completely, and that's from anything from your handpieces being maintained and processed properly, right through to like your chair and such like. But I do think I've seen an increase of it since COVID, where people are looking around for cheaper ways. If something breaks down, then it can cost sort of £200 or £300 just to get somebody to come out. There are companies now offering maintenance contracts, which we've done. We advise that people do that. We find it more cost effective.
I think that's a good idea.
Trying to cut down on, as we know, not having the validation it's like taking your car for a service and not having an MOT. You're not going to get away with it. You will get a problem of some sort at some point, be it breakdowns or litigation, problems, or CQC problems. And again, coming back to people go, oh, it's manufacturer's guidelines, but you've got to back all these things up. You can't just make these things fit to what you want or your budget. I think it's got worse as it's become harder to work within the NHS.
Yes, and also I'm hearing a lot about white space in diaries as well. So if there's white space in diaries, then that's going to reduce the income coming into the practice and therefore make people more likely to want to save money wherever they can.
And I had the conversation last week at a lovely practice. The owners at the end, and it is a very common theme. Owners want me to save money. They want me to look at what I can cut back on. And as a business development type of practice manager, I will always say, you are not going to save money. Your costs are going to increase. And the only way that you can make that bottom line healthier is to provide different treatments, ensure that the team ensure that the service you're getting, giving the patients is absolutely spot on, making them want to come back, and if you're doing that, then you might save a bit on marketing, but you're not going to save any money by chasing around to save a few quid on repairs and maintenance and things like that, because you're just going to land yourself in a load of trouble.
Yeah, well, it's very short-sighted, isn't it? I think a very short-sighted. Now, I think, Lisa, we've had a couple of questions which might be quite good to answer. So, Dal has asked, in regards to patient data, is there a form we send to the patient to complete to say they're happy for their record to be discussed with another person, I know you've not spoken about this, but it's a compliant issue I've always been unsure of. It's a really good question. Thank you. You should have a consent, a means of the patient giving consent to say that they are happy for their record to be discussed with another person. Now, this is sometimes when you have more elderly patients who perhaps one or other person may have dementia, or a mental health condition, which means that they need things to be discussed with another person. And ideally, you must get consent from the person, as in the patient, in order to be able to discuss their either their appointment or their treatment with somebody else. So a follow up there, I usually ask for the patient to email us from the address we have on their file. Yes, that's good as well. It is good though if you have a consent form within the practice that the patient signs that just says, I give consent to you sharing information about my appointments or my treatment with whoever it is. And within our compliance software system, we have those forms. So if you have a compliance software system, you should find consent forms for that. I mean, really, you should be getting consent, or you should get consent to send the patient marketing information. So there's a number of things that you need consent for, and discussing their treatment and their appointments with another person is one of them. What do you do, Lisa?
Yeah, we are very, I think, GDPR compliant, and very vigilant but sensible about it. If we've got somebody that's rang up and, you know, we can hear the person in the background and it's, you know, can I just stop you a moment? I just need to get consent from the patient. I think without overcomplicating this, we do have to sometimes have a seed of safeguarding to explore, depending on the nature of the situation, because we have to, is that patient giving consent or are they being coerced to give consent? We have to be a little bit aware. Yeah. But as you said, you know, I know dentistry has a very good form. I think it's really important to have a time date on this, because what one person may give consent at for one point, that may not be infinite. It might not be forever. And the same way, you know, crossing the T's, dotting the I's with, you know, data release, information release, getting patients to come in and bring a form of ID. Yes, we might have known this patient for ages, but again, we're following the process, we're following regulation, and we're not leaving ourselves vulnerable. Ask, you know, specifically, what are they happy for us to discuss? They might be happy for us to discuss their toothache. What we might not be happy with is to discuss the medical history. You know, we do, like we do with data, you know, people asking for medical dental records. We need to be a bit more specific about what they're asking for. We can't just chuck everything at them. And that comes back to the basic principles of keeping data safe, doesn't it, really?
It does. And I do also agree with you when you say you need to be sensible. So let's say you've got an elderly husband and wife, and let's say one or other of them is really not fully mentally capable anymore. And the one that is mentally capable says they want to be able to make that person's appointments and phone up about them. Well, you know, and GDPR strictly says that you shouldn't share that information without the patient's permission. However, you know, you've got an elderly person who is really can't remember when their appointment is. And I think you have to be sensible about it and proportionate as well. Just to go back to our questionnaire, to Dal, so I usually ask for the patient to email us from the email address we have on their file. I don't think that's good enough. I think that if it was a situation I've just described, maybe. but I think emailing from the address, it could be anybody sending that email. So I think it's somebody in person in the practice, and create. If you don't have a form, create your own. All it needs to say is, I give my consent to the following information being shared with the following person, and that's all you need to do.
Yeah, and list it, like we do with, photo consents. We've got photo consents for clinical, we've got photo consents for social media. What social media? How long? In what capacity is it going to be used for? We just have to be a bit specific, and it could be that you do it as a write it on the notes, not particularly on a pop-up or in the dental notes, but we actually keep a log of any kind of data exchanges that we're doing, which is always a sensible thing. And as long as we can rationalize it and show that we've actually risk assessed it in our heads. Ours is a very simple form, specifically how long they're happy to, indefinitely or just on this specific occasion. Just have a tick sheet and get people to fill it out. Anybody that argues with it about doing it, I'd be very suspicious of, because it's the law. It's not you being difficult. It's something that they have to do. So I think it's important. They're just slightly on that subject. I don't know. I haven't got the link to hand, but apparently there is now a portal that we can go onto with Government UK where you can actually search for power of attorney for people. Perhaps I'll look into that and get some more information about it. But I think people are finding that quite helpful.
Lisa, the patient provides you with a code. You have to supply your name or your practice name. They provide you with a code. You then log on and you can see all the permissions they've got on their power of attorney, whether it be finance or health, when it comes into place. For example, if they're compass mentis at the moment, but it says at this point so and so can take over. What I've not been able to get out of Denplan is how we record that. Nobody can tell me whether I can save the form, which I'm doing at the moment with that specific login because it's time sensitive, or whether you just write some notes. So at the moment I'm saving it in the patient's notes, and on the front screen I've got lasting power of attorney. But a lot of people don't know about it, but it's been about 18 months now it's been around.
I've not heard about it until quite recently.
Provide me with that link so that you can go on, because you then see the updated version rather than one that they might have done 10 years ago.
Yeah, I think, do you know what? Thank you so much for filling those gaps in for us, Michelle. I think that's really helpful. And I love the point, like we'd said about time sensitivity, Pat. I mean, one thing that does happen a lot is when we have record requests from people like dental law or other solicitors that like to get in touch with us, checking the patient's permission is valid and within 6 months of signing.
Yeah, absolutely. Yeah, really important. I mean, it's a very, very important subject, and I am wholeheartedly behind it. The only issue I have is this issue when you've got these elderly people who and you say to them, well, I can't share anything with you because I don't have the patient's consent, or I can't tell you if they're here or not, or I can't tell you when their appointment is even. And I think you do have to use some common sense there.
Again, I think it comes back to how we teach our team to communicate with people. And, we mentioned before about people not understanding. If people don't understand the whys, then they can, not do something properly, or in this case, get their backs up. I think, the conversation of it's really important to us that we get, your mum the care that she needs, we prioritise her. Her privacy. More than happy to get this sorted for you. However, we just need to go through a little process.
To
make sure that we are are, you know, compliant and putting your mum first and keeping all her data safe. And like I said before, unless you've got somebody that's absolutely off the rocker, why would they object to doing that?
Yeah, absolutely. No, absolutely. I completely agree with you. Any more questions from our audience? Please just pop them into the chat and we'll answer them as we go along. So on to sin number 4 from infection control, and that was sharp safety. Now, I think this is a tricky one because I think a lot of practices are not using, or dentists rather, are not using safer sharps, and I, you know, and sort of, it is true that if you don't feel that you are, it is as safe to use safer sharps as the conventional needles and syringes, then a risk assessment will suffice. But I think it's important that you do it for a good reason and not just because, well, I don't want to change because I've always done it this way. Because obviously if you use the conventional needle, then you have to work out how you're going to recap the needle and how you're going to dispose of it. And so what happens in your practice, Lisa?
We have some that do, some that don't. But we do, we did a risk assessment, and the dentist clinician prepares everything to hand to the nurse on the tray. We also do audits every 6 months where we watch that process happening.
Great.
We will just do, and it happens, you know, they get into the routine of it, you know, and we've never really had a problem. I've been in some practices where the accident book's full.
Yes. Yes.
They're occupational.
Me too. Me too. My favorite one was a practice I went to a long time ago, and the accident book said, and this is the exact words, the accident book said, Rachel stabbed herself, you see, on a needle, but that's how it was written. Okay, I said, oh dear, I'm sorry to hear that. And you know, is Rachel okay? Yes, fine. And then I looked through this accident book, and about once a week it was Rachel stabbed herself. And I said, well, what are you doing to stop Rachel stabbing herself? Because it isn't okay. Bearing in mind, this is a very long time ago. And they said, oh, well, we didn't realize we had to do something about it. We thought we just had to record it. And so poor old Rachel went on stabbing herself, and for all I know, you know, it was the end of her. But but I don't know that, obviously. But I think this comes back to, you know, if something doesn't go as you think it should, you need to put something in place to stop it happening, because otherwise, guess what? It goes on happening, and poor old Rachel goes on being a pincushion.
Again, it comes back to the whys. Why do we do it? Why are we doing that?
Yeah.
And how can we make it better? And you've got to just keep pushing with the team, making them understand it's not enough. They've gone on to a policy and ticked and signed it, and all this things that is going to protect them from stabbing themselves, and it's just not. It's about setting time aside to get the team educated on why they're doing things completely.
Yeah, definitely. And Lisa, those dentists that don't use safer sharps, what is the reason they give for that?
They find it generally much more difficult to dispense, to inject.
Sure.
They find it really difficult, and I suppose it's one of them things that they get into their own routine of, and then they've got this implement that's making them, sort of right with the left hand when they've always done it with the right, kind of.
Yes.
And I suppose when you look at it like that, you can understand if they don't feel capable or safe doing it, then that's actually going to make things probably more dangerous in ways.
Exactly. I think that's exactly right. And I think if they genuinely feel and believe that they are safer using the traditional needle and syringe. And then obviously that will be on the risk assessment. But what I think is wrong is those dentists that say, well, I've always done it this way and I'm not going to change. So I think if they've tried it and genuinely don't get on with it, then absolutely, because then they're genuinely putting patients' best interests first.
Yeah, we have to at least explore safer options, don't we?
Yeah, absolutely. And then so those dentists that don't use safer shops, they then they dismantle the needle at
Matrix, everything.
Yeah. And then they put it in the sharps bin, do they? Or how does that work? Yeah.
Absolutely. Yeah. They should, there should be no danger.
Yeah.
And, you know, I mean, it does scare me, you know, I go in practices and we've got apprentices that are, you know, dismantling syringes and
dear.
not even had their full course of Hep B, and it's like,
oh dear.
And they're oblivious to the dangers, you know. But we're also oblivious to the fact that they've not got Hep B and passing that on to patients. So it's like,
well, you need the tiniest amount of blood and saliva to pass on Hep B. And another scary statistic from the lecture was that we all, when I say we, I mean clinicians and therefore dental nurses as well, treat one unknown Hep B carrier a week each. And again, I don't know where Mike gets his statistics from, but you know, given that he's a professor and a scientist, you know, he won't have made them up. So you know, and you need this tiny amount of blood and saliva to transmit Hep B. And if you are if everybody is seeing one carrier or somebody who is infected with Hep B a week and they don't know about it, that's a good enough reason to be doing everything as you
100%,
should.
yeah, 100%, and that's just Hep B.
Yeah, that's just Hep B. Yeah, exactly. Which is the easiest of all to transmit. So that I think is quite worrying.
I think I see more practices having problems with injuries from matrix bands than sharp.
Really? Yes. Yeah. That is, well, which is why having the Hep B jab is so important. But I think you know, but then again, you know, saying that the dentist is dismantling the syringe themselves, but the dentist is at risk as well. You know, so I know that you know, we're all focused on making sure that the dental nurse doesn't injure themselves, but the dentist can just as likely injure themselves. So, you know, the fact that they're dismantling the syringe themselves means that the nurse is protected, but it doesn't mean they're protected. So they need a safe way of recapping the needle and dismantling the syringe. So how do your dentists recap the needle?
Oh, that's a good question. I don't know actually. I've got one in the background that's just walked in. Diana, how do you your needle, your syringe?
I have to put the hub on the floor on the kind of surface and go like that.
Okay, so kind of put the hub on the surface and do it like that. So there are obviously processes that are thought about.
Yeah, absolutely. I mean, those things things that you can put the syringe into and then it sort of grips the needle and that allows you to do it. But I think that method just described, I think, is perhaps not as safe as it could be because you can still miss. So something to look at.
Maybe. Absolutely. Yeah. Every day is a school day.
Every day's a school day for everybody. Well, I'm enjoying sharing my school day with you.
So I love it. It sounds great. This course does.
Yes, it was really good. And then sin number 5 was not. So we're now down to only 27%. incorrect segregation of waste, which is a whole, we could spend a whole session on this, because I'm sure everybody knows that the new guidance has been published called HTM 0701, the Safe Management of Healthcare Waste. And do look out for the article I've just written for Dentistry magazine on this, because I found it quite a difficult article to write, because for years and years and years and years and years, forever, in fact, we've been told you treat everybody as if they could be infected. Now, what HTM 0701 wants us to do is to only treat patients with a known infection as if they're infectious. And so my question would always be, how do you know if somebody's got an infection? And you know, going back to the transmission of a Hep B, you don't know. So I suspect a lot of practices will continue to put all their clinical waste into orange bags, and they will continue not to follow the guidance in HTM 0701. But what they say is what the guidance says is that you segregate the waste out into clinical waste from a known person with a known infection, and that goes into an orange bag, and the waste from somebody who doesn't have a known infection, but the waste is still what they class as offensive, goes into tiger stripe bags. So what are you doing in your practice, Lisa?
We are quite diligent with the segregation, and I know Julie spent a lot of end of day, I even followed around on quite a few occasions, looking at the spot check, you know, doing a spot check, and she bought herself this rather handy little tool thing that meant she could have sort of audit them to make sure things were going in correctly. I know cost seems to be coming up in conversation for a lot of people with the move to zebra bags, but I think it does vary on whichever company you are using, because the guidance up to now, well, it used to be whatever your waste provider or controller is advising you, but we're getting to the we need to move away from that now, don't we?
Yes, yeah, definitely. Yeah, definitely. Well, the snappy title, I know, the Safe and Sustainable Management of Healthcare Waste, it's called now. And I think the sustainable word is really important. So what they're trying to do with the guidance is to cut down on the amount of waste that that is incinerated, because obviously that creates carbon emissions. And you know, I feel really conflicted in this, because I agree that we are terrible in dentistry in terms of reducing unnecessary waste. So things like we use far too many plastic disposable things. I gave a lecture recently at a study group, which was all dentists actually, and there was nearly a riot when I said you shouldn't be using plastic mouthwash beakers anymore, and they said, well, we've always used them, but you know, producing all this plastic which lasts forever, we just can't go on doing it. So I do think that the sustainable element is really important.
I agree. I think it's really interesting when, you know, I've been in practice for 30-ish years now, and I think you do, over the last sort of 10 years, you've seen a definite shift in the younger generations. It's like breathe into them, you know, we should be more sustainable, we should be more recycling, more saving, on, you know, not wasting things. And I think yeah, it's not that us older ones don't adopt it, but it's not been ingrained in us in the same way that it has some of the younger generations. You know, there's dentists that, you know, are quite happy to use the single-use plastics, and then they're also reusing burrs, and you know, there's
yes,
files, and there's things happening that I'm like, you know,
Yeah.
we don't mean,
Yeah.
use things that are potentially harmful. But
Yeah.
certainly little bits where we can. Plastic, paper cups is easy.
Yeah, it is easy. It is easy, and I was surprised actually. Actually, that the person that said really objected to it said he'd been told by the CQC to use plastic cups, which I find very difficult to believe. So
Yeah, that's odd. I mean, it's sensible steps, stacking them rather than chucking them in,
yeah,
it's the little things. I mean, we've got segregated, in our drawer, there's two sections, one section, and then we've got obviously like the hard waste and such like. And it did take a little bit of spot checks and reviews and conversations to get people into the right habit. Again, goes back to them understanding why. And I think from my point of view, Jill is telling them why from a compliance point of view, and then I'm there telling them from a, do you know how much this costs if we don't don't do this correctly? We spend probably an average practice of an average size, probably between £300 to £500 a month on clinical waste disposal. And that's huge.
I think paper cups going into offensive. I think if you're going to follow HTMO 701, then paper cups go. This is a question asked by Michelle. Should paper cups go into offensive or somewhere else? If it's a patient with no known infection, then yes, they go into offensive, and then to tiger stripe bags. But I think we can also look at, I mean, there are autoclavable solutions as well you can use. So things that
I think those autoclavable ones are good, but then we are then using energy.
Yes.
So
it's a heads you lose, tails you lose situation, really, isn't it?
I know.
The other things I think we ought to question are, and having spent years saying that you need to use disposable 3-in-1 syringe tips and saliva ejectors and autoclave aspirator tips. I now think we should just question that. You can get some really good autoclavable aspirator tips. That no reason why you would not use them. So get rid of plastic aspirator tips. Saliva ejectors, I think, are more difficult because they are extremely difficult to clean. But then so are lots of other things. So I think, but just ask the question. So Michelle has said it's a full circle for us oldies. You're so right. at least nobody does, Michelle. At least nobody does what they did. What happened when I first qualified, which was that we sterilized the instruments in a hot water sterilizer bath.
I had one of those. If I had Dettol in a Tupperware container to start with, I remember the first autoclave. We were like, "Woo!" But that was only for extraction forceps. Nothing else but extraction forceps in your autoclave.
But I think
we're probably all guilty of, I'm the first to admit that dental nurses have it much harder now. But then in some ways, what we did was quite hard. And it's like, well, back in our day, oh God, dental nurses continuously, I think I had a bruise on my head for the first 3 years of my career from developing x-rays into the stairs cupboards. I'm sure that was in the accident book quite a few times.
Lisa banged her head.
Full circle, Michelle. That's a good shout, actually.
Oh, absolutely. But you know what? I'm not saying I've got the answers to any of these things. I'm saying think about it. Think about, the fact that plastic is pretty much indestructible. And where you can, well, it is indestructible, unless you're looking 500 years down the line. But I think where you can reduce it, do. Right, Laura, could you please remind me what year it came in that you need 2 references recorded for new staff. I've been racking my brain, just can't remember. 2011. So 2011, when the CQC arrived, they decided that that you should have 2 references for new staff. Now, references are, well, again, it's going back to the old days. You know, if somebody had been a nightmare in your practice and somebody else asked for a reference, you could give the reference that says this person's a nightmare, don't employ them. You can't do that anymore, though. So it's very limited what you can say on a reference. CQC does still require you to do it, but it is very limited. All you can really say is that this person was employed in my practice from this specific date, as in day, month, year, to this specific day, month, year. Now, in terms of references, you quite rightly, Laura, said for new staff, and you should get references for new staff. And actually, in our practice, we came unstuck not asking for a reference a number of years ago, and it turned out that everybody knew this was somebody we shouldn't have employed. But anyway, and then, but the CQC does like to see references for everybody if you can, but if you've got somebody who's been in the practice a very long time, then character references, I think, are
Can I just add to that, Pat?
Yeah,
I've seen an increase. If we employ quite a few people, and obviously big turnover, not big turnover, but a turnover that's probably bigger than a smaller practice. And I'm really still shocked at how many people don't ask for references. Now, for me, if somebody's not asking for a reference, they either just don't know about this, the need for it, or they're so desperate they don't actually care. What I do find is that if I get a reference for somebody that's not the previous employee, or a hygienist, or a practice manager, or another nurse, sometimes when employees leave, particularly if they're disgruntled, then they won't ask the employer to provide a reference because they think it's going to be bad. For me, I'm pretty sure that this is what we're advised from our employment law solicitors books and codes. The only person that should be given a reference of employment is the owner or the practice manager. They shouldn't be getting that off another employee or self-employed person in your practice. And I would question anyone that doesn't provide one from the previous employer. That's my opinion.
Can I just put in and say, when you're getting references, please make sure you do your personal email. I had a company email reception, or a reception email, and somebody followed the link and filled it out with my name on it.
Oh, wow, that's naughty.
Yes, for their own reference, because they were leaving. So it had gone to reception, possibly given that email address on purpose. It's only because I found out and challenged it and went to the company and said that wasn't me, and you mustn't send things to a generic email, and you need to make sure it's that person that's sending it back, because there was nowhere, no signature on it, no nothing.
No, I generally ask
just
for...
be a little bit wary.
Oh, Michelle, it happens. I'm sure it's happening. I'm sure it's happened multiple times across the country today. Not just in dentistry. I think in any business.
Absolutely, and obviously really important that you check that people have the right to work in the UK, and also check their DBS as well. Good. Well, I can see we're now on 1 minute past 2, Lisa. So I think, does anybody have any more questions or anything we can help you in any way, or suggestions for what you'd like us to cover on future Lisa and Pat have a chat sessions?
Has anybody got any suggestions for cheap paper cups? Because we can't get any
none, sorry.
Oh, great, thanks.
Lisa,
I don't quote me on this, but I've got a feeling that my girls order from Denka.
From where, sorry?
Denka.
Is there someone else
DENK.
then?
I'll type it in.
Yeah, thank you. I know what you mean. It's just sounding like something else.
I think it's
Yeah, no, I use Denka. I'll have a look.
they're a nice family run company as well.
I like using them.
Yeah, I do like them, definitely like them. But yeah, please, as Pat said, you know, let us know what you want or would like covering at some point. Oh, Julia's put, I think Next Dental have cheaper than Denka. Yeah, well, let's if anyone finds somewhere cheap.
I mean, it's not obligatory to have a mouth rinse cup anywhere, anyway. So you know, I think I do know practices that don't use mouthwash cups at all. So yeah, so I think it's difficult, I think, but and as we discussed earlier, there are autoclavable alternatives, and given that you'll be autoclaving it alongside other things, which you'd have to autoclave anyway, you know, Lisa, you're quite right, you are using energy, but you have to do that anyway, and there's no way around that. So maybe an autoclavable alternative is a good plan.
Yeah, I think, you know, reducing it, as you said, you know, the rinse should be there if it's needed. It's not part of the routine. Obviously, the dentist needs them to. Fine. And if they ask for one, we're not going to begrudge them. But you know, if you think
absolutely,
you can reduce that by 50% a day in each surgery, it's massive.
Yeah, absolutely. Yeah.
Because they probably don't want it sometimes. It's just that they feel like that's what's expected.
I know.
All good. Oh, do you know what? You've been a really, really lovely group.
Yes.
And that was, we always enjoy these sessions, don't we?
We do.
As usual, everybody.
Well, there you are, Laura.
It's always great. We could yeah, so if anybody has any questions, I know Pat's happy for people to contact her with Dentistry Compliance. I know many people have moved over to Dentistry Compliance, and I think it's great, the things that you're doing and still looking at improving and progressing with is just it's lovely. It is definitely made with practice managers in mind. And most of my clients, most of them have moved over now, which I'm so happy about.
Yeah, that's the idea. You know, make it as easy as possible for practice managers. Don't take something complicated and make it more complicated. You know, our mantra is let's try and make this as simple as we possibly can.
Yeah, no, absolutely. Thank you so much, Pat. Thank you, Sam from ADAM, for helping to organise us and remind us to register ourselves.
Yes, exactly.
So we will see you all in. We have got a date for January. I can't remember top of my head when it is, but please keep an eye out for it, because as always, there's probably going to be more changes, more things to have on our radar. And Pat, you're just an absolute fountain of compliance knowledge, as always.
Thank you, Lisa. Thank you very much, and Merry Christmas to everybody, and a happy and healthy 2025.
Yes,
thanks very much.
All right, take care.
Take care, guys.
Thank you.
Thank you.